Okay, so let's start. Quick disclaimer. So the speakers won't be able to discuss personal medical questions, give personal advice, because obviously they don't have the whole story, your all medical records. And also we are able to do this kind of webinar thanks to your donations. NF2 BioSolutions is focused on raising funds to sponsor research, novel therapy research for a long-term solution to NF2, but as well, we are organizing this webinar for the community. And since we are spending many hours to prepare this webinar, we don't spend these hours at fundraising, so we will appreciate if you can support us. You can see also all our previous webinar, the webinar about NF2 care, but also about update about the research. You can see that on our YouTube channel called I Need a Cure. You have the link as well, youtube.com/I Need a Cure. And you will see all of our previous webinar. And this webinar will be recorded and will be also on YouTube. So we think it's a very important webinar. We did a webinar in the past about surgery care, about radiosurgery, about understanding NF2. But this webinar, I think, is one of the most important. Treating our vision, the vision of the NF2 patient is critical. It's critical, as you know, we have very high chance to lose our hearing. So we have to make sure we have good vision so we can keep the balance, and also we can keep communicating with other people. I just came back today from the neuro-ophthalmology visit of my daughter. The photo that you can see here, this is my daughter, Karen. She was diagnosed at 6 years old. Now she's 15. And we just did a few tests. She had a field vision test, a OCT test, and then a visit with a neuro-ophthalmologist. Everything was stable. We follow up her vision because she had a cataract when she was little, a juvenile cataract, and also she has a traction on the retina, and we did a preemptive laser so the traction doesn't spread. So that's a very important webinar. If we can diagnose also early on the NF2 patients, we as an NF2 patient, we have more option as well for treating our NF2. So without ado, I would be quickly introducing our panelists. We have here Dr. Gareth Evans from Manchester, St. Mary Hospital Medical School. Dr. Gareth Evans is an NF2 genetist, very well-known, renowned in the NF2 community. He developed several clinical service for cancer genetics, but also for NF2 patient, an NF2 clinic that is internationally regarded. And Professor Evans published hundreds of research and publication on NF2. We have Dr. Yagan. Dr. Yagan also from Manchester, a neuro-ophthalmologist and ocular motility surgeon. He's an associate medical director at Manchester Royal Eye Hospital, director of medical education, and ophthalmology lead for the NF2 service in Manchester. And we have Dr. Sharma from Oxford University in UK as well. Dr. Sharma is a clinical scientist doing research, and she is the head of the neuro-ophthalmology and ocular inflammation service in Oxford University Hospital, and ophthalmologist for NF2 service. And today was just the day where she saw many NF2 patients at her clinic. So thank you very much for joining us. And we will start, we will have first a few presentations from Dr. Evans, Dr. Yagan, and Dr. Sharma, and then we will have Q&A. We will go through your questions and then try to answer many of them. So let's start with Dr. Evans. Thank you for joining us. I'm going to unshare my screen. And then Dr. Evans, you can share your presentation.
Unfortunately, my video is a problem. I've tried to join from, let me see if I can now join from the other laptop. So
that's fine. Maybe you can turn it off. Currently, it's good. Your camera is good.
Okay.
Anyway, it will be a small window as well, so it won't be too bad.
So I'll start sharing. Gosh, it's taking ages to open. I apologize for this. Screen sharing has stopped.
Yes, you stopped it. Can try again.
Okay, try it. There we are.
It's coming. Yes.
So I'm just going to give you a bit of a background. The real eye specialists are going to come after me. I'm sorry if you're looking at my psychedelic pictures, because
if you could go full screen, please. Full screen.
Yep, full screen.
Thank you.
Okay. So I was going to take you through some of the eye features and how they can be really important, particularly in younger patients in diagnosis, because they can sometimes be the first features of NF2 that occur. I think what I want to emphasize from the start is, although there are a lot of eye features and they are now quite important in making diagnosis of NF2, particularly if there are not other clear features, it's actually pretty rare for eye problems to cause blindness. So they can cause loss of vision, but it's really quite rare for there to be complete loss of vision, even on one side. So these were the Manchester diagnostic criteria that we developed in 1992. And as you can see, the typical feature is the vestibular schwannoma, the hearing and balance nerve schwannomas that occur on both sides. And in fact, they were the critical diagnostic feature in the first set of NF2 criteria by the National Institutes of Health. And virtually every NF2 person will develop bilateral vestibular schwannomas in their lifetime, and indeed most are diagnosed at presentation with the tumors on the hearing and balance nerves. But that may be the only feature in very mildly affected patients. You can see here the original criteria did have cataract, and meningioma was also something that could occur on the eye nerve, although, as I'll show you, it's actually not that common a feature, and certainly getting it on both sides is extremely rare. Now, the criteria have recently been updated in genetics in medicine, and we now call NF2-related schwannomatosis. So the term neurofibromatosis is now defunct because you do not get neurofibromas in NF2. You get schwannomas, which are the type of benign tumors that occur on the nerve sheath. Now, you can see from these new criteria that there are more eye features. So you can see here, we've now categorized that the eye cataract, so the darkening at the back of the lens, has to be under 40 years of age. We've also added something called a retinal hamartoma, which is a benign change on the back of the eye, on the retina, that where you perceive your vision, but also epiretinal membranes, age less than 40 years of age. So there are now many more ophthalmic features, eye features, in the diagnostic criteria. So if you don't present with bilateral vestibular schwannomas, which give a definite diagnosis, you can use eye criteria, particularly in young children who may not yet have vestibular schwannomas, to make an NF2 diagnosis. But obviously, if you see eye features nowadays in very young children, we typically go to do blood testing for genetic faults in the NF2 gene. Now, you do get schwannomas on other eye nerves, and this is a child who unfortunately had quite a severe, at the age of 2 or 3, had this trigeminal schwannoma, which actually stop the eye working on one side. And that is extremely rare also. In fact, that's the worst trigeminal schwannoma I've seen in over 600 patients. So it's very, very rare for that to happen, but that can affect the eye. So the main eye features are the typical posterior subcapsular cataracts. So these are the ones on the back of the eye. They rarely affect vision. They rarely require removal, but they can at some stage cause a little bit of visual loss. The cortical wedge opacity are the ones which tend to occur at younger ages and may cause problems with vision or cause one eye to switch off early in childhood. Retinal hamartomas rarely affect vision. They're really something that our eye doctors see, but very occasionally they can affect vision. I'll show you an example of that. The epiretinal membranes, again, rarely affect vision, but they're a feature that can be seen by ophthalmologists. The optic nerve meningiomas, as I said, not that many, only around 1 in 20 or less with NF2 will get a benign tumor on the eye nerve. But probably one of the commonest things that actually is symptomatic is that we have a very high frequency where one eye doesn't work properly from an early age. It gets switched off by the brain, and that eye has poor vision, and often there is no obvious cause for that. So on the left here, this is the most serious retinal hamartoma I've ever seen, and in fact that was in that same patient in his other eye. So you can see here a large proportion of the retina is taken over here by this retinal hamartoma, and on the other side this is a darkening at the back of the lens, a posterior lenticular opacity. So the eye cataracts rarely impair vision or require surgery. So that's the important thing, that although they're a feature, it's really uncommon for there to be significant loss of vision. The optic pathway meningiomas, again, relatively uncommon. They're often an incidental finding on the MRI, so not symptomatic, but they can cause significant visual impairment. They can present very early in life as well. And in fact, when I went around the UK 30 years ago, seeing patients with NF2, I came across 2 who actually had their eye removed for meningioma disease, which I think was because it was mistaken for retinoblastoma at that stage. So in my personal series of 608 NF2 patients, 22 have had optic pathway meningioma, so relatively low, and 2 have had these on both sides. Certainly from my own experience, and I hope that my colleagues will back me up here, we do see quite a lot of amblyopia. And this is usually not associated with an obvious cataract. To emphasize the real importance of the eye early on, and this is work that was driven from the Oxford group, but was UK experience in the early days of our UK service, which started in 2010. There were 32 children with no family history. So the presenting feature of NF2 could be, in this situation, an eye problem. And of those presenting under 5, 89% had ocular abnormalities, 17 out of 19. And 12 cases, that's 38%, presented with visual impairment. So one of their presenting features was a problem, either a squint or a nystagmus or a ptosis, that was their presenting feature. And this is just a sort of breakdown showing you that the younger you get, the more likely it is when you present that you will have eye features as part of your condition. Although, again, I emphasize this doesn't mean that this will end in complete loss of vision. It's rare for that to occur. So other recent features, again, led by the Oxford group, a special type which maybe one of my colleagues will talk about, called optic coherence tomography, was able to identify a new NF2 feature called a retinal tuft that was only seen in NF2 patients and not the controls that were looked at. Retinal hamartoma, slightly more than I showed, but this might be that the series was more typical NF2, epiretinal membrane a little bit less than that. So there are also clear evidence of genetic severity. So genetic changes that cause NF2, that cause a more severe type of NF2, tend to be more likely to be associated with eye features. So there's some evidence of reduced visual acuity as a result of having the worst type of NF2 genetic fault. And you can see this here, that the severe group had evidence of reduction at 38, the moderate at 49, the mild classics at 64, and the mosaics, that is where you have not inherited the gene fault in your egg or sperm that makes you, but the gene fault occurs as you develop in the embryo. And if we can't see it in blood, it's at very low level, and actually eye problems in that group are really very rare. So the conclusion of my little bit is that eye features are often the first manifestation of NF2. Visual loss, cataracts, retinal features in childhood should prompt evaluation for NF2, and there may be many of you listening or parents of children with NF2 who will recognize that maybe an eye problem was there before the tumors were diagnosed. So overall, most eye features are not associated with substantial visual loss. So I'll hand over there to my colleagues.
Thank you, Dr. Evans.
Unless I'm taking questions now.
No, not yet. Let's have Dr. Yagan share his slides.
Thanks, Gilles. I'll start the share if I can. And then let's see.
And if you have questions for the audience, you can type them into the Q&A, and then we will discuss them after the presentations.
Showing?
Yes.
Great. Thank you, first of all, for the invitation to talk about the ocular manifestations of NF2. My name is Ali Yagan, as introduced, and I'm one of the neuro-ophthalmologists in Manchester. Nothing to disclose. I work in Manchester. I've been in Manchester for nearly 25 years, working in the eye hospital probably for half of that time. Originally, I'm from a country known as Syria. Lots of people would know Syria these days for all the wrong reasons. So I just put a couple of slides showing my home city and where my basic studies were done. Right, so NF2, as you all know, is quite a complex disease. It's really difficult for one person to manage it, or one subspecialty or specialty to manage it. You'll need people from all disciplines to try to work together and provide the best care. And that is clearly shown when the excellence centers in the UK developed. I think the care for NF2 took a quite significant change, and the outcomes are clearly reflecting that. So the team involved genetics, involved neurology, neurosurgery, oncology, ENT surgeons, audiology team, ophthalmology, neuroradiology, physiology, you name it. You need lots of people inputting on different various things because the disease is so complex and involves multiple systems. So why ophthalmology is necessary? And I think really 2 points to emphasize here. One obvious is with the risk to hearing, I mean, you talk to patients and they'll all, regardless of whether they are an F2 or not, they will say to you, my vision is very important to me and prime to me. That's even more important when there is a risk to hearing. The main usable sense would be your vision, and we need to make sure it's protected and safe. On top of that, there are multiple ophthalmic features that we've discussed and we will continue to discuss that are really important to kind of pick up quite early on, monitor, and perhaps treat if necessary. And I'll touch upon some of these features, how to diagnose them, and what are the things that we use in our diagnosis. So briefly touching on the cohort in Manchester, and we presented this in Nanos a couple of years ago now. We looked at nearly 700 patients, and the unfortunate bit was not all of them were screened by ophthalmology, but the ones who were screened by ophthalmology had kind of lots of ophthalmic features. Nearly 85% of them had ophthalmic features. Obviously, the commonest was the facial palsy, which leads to various things affecting the eye surface, the dry eyes, the inability to close the lid properly, all these things. But also there are things that are specific to the eyes, like the cataract, the eye movement problems, and the patients suffering from what we call cranial nerve palsy. So they end up with eye motility problems and double vision. You get the features on the retina, the hamartomas, the retinal tufts. You get the visual pathway, the optic nerve tumors, which can be either a meningioma or a glioma, which is even rarer. But the percentage is, as Garrett mentioned, is around 4 to 5%. Papilledema, swollen optic nerves, in other terms, because of the raised pressure in the brain, simply because these patients unfortunately would have multiple brain tumors, meningiomas or schwannomas that can raise the pressure and cause the swelling to the optic nerves. So this is just a quick breakdown of the things that we found in our cohort, and it shows clearly the importance of having an ophthalmology input is very important, specifically in the NF2 kind of. So as we said, we screen for ophthalmic features, we monitor the visual functions and make sure they're not deteriorating, and if they are deteriorating, then we can manage or treat these things, whichever kind of needed, like surgical intervention, laser, other things that can be done to try to preserve or improve vision. How do we do that? Well, there are various things that we assess. So basic kind of ophthalmic examination involves looking at the visual functions. So our eye can provide various things to our brain to see the world with. And the first thing is what we call the visual acuity. So the ability to see clearly in our center of vision, and that's tested by the visual acuity. But also we have color vision ways of testing. So we test for color vision deficits. We also look at the peripheral vision, and there are a couple of ways of testing that, and I'll share that with you in a minute. We also look at how our pupils react, because the pupil reaction is a clear indication of how our optic nerves function. So it tells us how our optic nerves are functioning and if there is any asymmetric problems with the optic nerves. And we also can look at how our eyes work together. So there are ways of testing our vision to make sure our eyes are cooperating together and working together to produce the three-dimensional vision. So how do we test visual fields? The simple way of doing it is confrontation field testing. So confrontation field testing essentially is the examiner or the doctor examines the patient's visual field using their own visual field. So they compare their own visual field with the patient's visual field by showing them targets in different areas. And if the examiner sees the target, then the patient should be able to see the target. Otherwise, there is a problem there. The other way of doing it is what we call a static visual field. So similar to the one that Gilles had, well, his daughters had a field test. It's the simplest way of doing automated visual field testing. It's a kind of relatively large machine. The person puts their head inside a ball, and then the machine shines different light targets, and the person need to press a button to tell the machine that they've seen that target, and then it gets plotted on a piece of paper. And then it's very useful to compare with time. So it allows the examiner to track changes with time and make sure that there is no deterioration to that visual field. Similarly, as I show in the previous picture, we can do something called Goldman visual fields, and it's a little bit more complex to do, but it's a little bit more comprehensive as well, and it allows us to go further out in the periphery to test our peripheral vision. So these are ways of testing peripheral visual functions. Once we've done that, we start the eye examination, what we call from the front to the back. So we start with examining the lids, making sure that the lid function is normal. They can close the lids properly. There is no kind of difficulty in opening or closing the lid. Then the next layer is the cornea. So it's the front window of the eye, and it's important to make sure it's safe and well protected, well lubricated, and clear from any scarring or any kind of ulceration. Because, for example, in patients who have facial nerve palsy, they are unable to close their lids properly, and that would lead to corneal abnormalities and corneal problems. Then we examine the lens, as Gareth mentioned. We look at the cataract, and if there is any cataract changes, we check the intraocular pressure, and then we look at the fundus. So the fundus is the back of the eye, and essentially we're looking at two things: the optic nerve and the retina. So these days we still do the clinical examination, but we also depend quite a lot on lots of machinery. And one of the common things that we do is something called optical coherence tomography, or OCT. And essentially it's taking pictures to the back of the eye using light. And it allows us not only to see the back of the eye, but also to look at layers of the optic nerve or the retina and make sure it's not kind of damaged, or if there is any changes, then we can track these changes with time and make sure it's not progressive, or if it's need to be treated, then we can treat it. And these are a couple of examples of normal OCT scans of the optic nerve. And you can see the clever kind of bit of software. It not only takes sections through the retina or the optic nerve, but it also compares it with the general population, and it can tell you that this patient's optic nerve looks completely healthy and similar to what's expected in the general population. So what do we see in ophthalmic examination? So as we said, let's start from the beginning, and I'll show you some examples really more than anything else. And then my colleague Sri will talk about things in more details, I guess. So these are examples of lag ophthalmos, or a condition kind of as a that happens as a complication to facial nerve palsy. So patients with severe facial nerve palsy are unable to close their eyelids properly, and that leaves part of the surface of the eye exposed to dryness and to the elements, and then sometimes it gets ulcerated and need to be intensively treated with lubrication eye drops, with antibiotics to make sure it's not infected, etc. But long term, in these scenarios, for example, you can see here that this patient, unfortunately, unable to close their lids properly, then we implant a gold weight to make the lid a little bit heavier, so it sits lower and it closes that gap to prevent the dryness and the ulceration. And dry eyes are quite common in NF2 population, simply because there are multiple reasons for it. So the cornea's sensation can be reduced if there is a problem with the trigeminal nerve or the fifth nerve in the brain. The tear production can be reduced because of the facial nerve palsy and issues with the facial nerve. And the inability to close the eye properly can lead also to dry surface. And they will need extensive lubrication and sometimes surgical intervention to correct that dryness of the surface of the eye. Next thing is cataract. So cataract is, as we said, is darkening or haziness in the lens inside our eyes. So instead of having a clear lens that takes the light all and focuses at the back of the eye, you get scattering of the light inside the eye. And that can be either in the center of the lens or at the back of the lens, as Gareth mentioned. So posterior capsular subcapsular opacity. And we treat it with surgery when it's needed. So the key message with the cataract is knowing that it's the reason for the reduction of vision. It's significant enough to warrant surgery. Because majority of cases, as he mentioned, do not really need surgery simply because the cataract changes are very mild and non-progressive. And these days we do what we call phacoemulsification. So we go with a small incision into the eye, we take the cataract out with ultrasound, and we put an implant lens inside instead of the natural lens. And these are some of the the images from our own sort of patients. So you can see that these are the cataract changes, patients ready for surgery, and this is how we do it with an instrument inside the eye. Looking at the retina, you get the common things like the hamartomas and the epiretinal membranes, but also, as Sri would expand further, the retinal tufts that were found to be very kind of specific for NF2 patients, and it's really key to screen for these. You can see some of the OCT images of our own patients where you can see the changes in the retina, where the normal retina on this bit looks quite normal and structured, while here you get all these changes that are kind of all the layers mushed up into one big blob and some traction on the surface. And again, the clever software tells you that there is an abnormality here, and it outlines it. It's helpful for us to monitor that with time, and if there is an increased traction, perhaps lasering or surgery might be necessary for that. You can see another patient here with another area of retinal hamartoma, and it's clearly demarcated on the OCT image. This is an image of a patient who had an optic nerve glioma. So it's a tumor to the nerve head, and it's kind of affects the vision badly. So that patient has very poor vision in that eye, but luckily it's very, very rare. It's less than 1% in the NF2 population. You get optic nerve sheath meningiomas, which are probably somewhere between 4 and 5%, and these can be mild, which do not affect vision, like these here and here, or can be big. And if they are big, then they will probably start to affect vision and reduce the visual functions. And also, because they are big, they can cause changes to the appearance of the eye. And I'll show you an image of that. So this guy, unfortunately, has a massive orbital / optic nerve meningioma, kind of affecting the whole of the orbit area. And it's pushing his eye forward really badly. And it's causing not only the poor vision in that eye, but also, unfortunately, the exposure and the inability to close the eye properly. He went on to have surgery to remove the bulk of that tumor and help with his kind of the preservation of his eye. You can get, as we said, you can get papilledema or swollen optic nerves. So these are images of patients who had really badly swollen optic nerves. This is not because of an NF2 tumor affecting the optic nerves, but because that the tumors within the brain structure or the brain volume increases the volume in the skull and causes the raised pressure, which can push the nerves forward and cause the swelling. Now, this can be mild or severe, and if it's severe, it can lead to long-term damage to vision. But luckily, again, this is very rare and usually get treated quite early on. And the treatment is not from the eye side of things, but it's mainly to reduce the intracranial pressure, usually by surgical intervention to the causing tumor. As I mentioned, you can also get eye movements abnormalities. So these are some of the images of our patients who have multiple issues with how they move their eyes. So this lady had a tumor in her left orbit, and there are difficulties in moving her left eye in certain directions. So for example, she's unable to fully look either upwards or to the left, to the right. So there are limitations of eye movements, which creates double vision because her eyes are not working together anymore. This is another case with a similar problem. So a couple of patients who have something called fourth nerve palsy. So they're unable to look down and inwards. So this guy had it in the right, so this lady has it in the right eye. So the right eye is unable to move all the way down compared to the left one. The other patient has it on the other side, so it's on the left eye. So this eye is not able to move fully compared to this eye. And that creates double vision in certain positions of gaze. Similarly, this lady had a third nerve palsy. So she's unable to, you can see that somebody's lifting her lid up because that lid is drooping down. And also she's unable to look up. She's unable to look to her left. She's unable to look down. And that creates really complex double vision pattern, which might need some surgical intervention. Another case of something called a sixth nerve palsy. So this lady is unable to look to the left because her left eye has a sixth nerve palsy. So again, in primary position, in the looking ahead position, she will get double vision, and more so on the left side. And this is treated surgically in majority of these cases. So this is some of the images for our own surgery. So we can operate on these muscles, as you can see here, and we try to create a balance again to, although we can't access the nerve and make it function better, but at least we can access the muscles that are fed with these nerves, and we try to create some more balance between the eye movements, and that helps with the double vision. And thank you.
Thank you very much, Dr. Yagan. We will take questions after the presentation of Dr. Sharma.
Yep, I'll stop you here.
Great. Thanks very much, everyone. I'm just going to. So can everyone see the screen okay?
Yes.
Yeah, fantastic. Okay. Hi, everyone. So today was a day which I spent with a whole lot of NF2 patients. So it's a perfect timing for this wee talk. So I'm going to keep it really practical, and everything I'm saying today, I've talked about with my patients all day long. So please do save your questions for the end. And let's start. So Dr. Yagan has really nicely set the scene for some of these very simple practical slides that I'm going to share with you, but I just want to reduce it all down to some really key points. So as eye doctors, our management or our treatment really consists of a few main areas. That's it, really. And our purpose is to, there's a fancy word, corneal exposure. It just means that the eye gets dry and we may not be able to close our lids because we have a facial nerve palsy or a fifth nerve palsy. This means that vestibular schwannoma, which is the most common tumor that we have in NF2, is causing some compression or damage to these nerves. And as a consequence, the eyes bear the brunt of this problem. So people can get, so our management or our treatment focuses on treating the dry eye for those who have symptoms and those who don't, protecting the cornea and preventing scarring, which I've certainly seen today in patients who didn't know that this was happening to their eyes, preserving vision, which can occur from scarring of the cornea. And the cornea is just that window, that first surface of the eye. And if you turn your head to the side, look in the mirror, you see your eyes, your eye bows outward, and that curve is the cornea. And then the final bit is preventing facial nerve damage. How do we prevent it? And so therefore protect the eye that way. And the next main theme is vision impairment in children. They're a very special group of patients. The third, not so common, but tumors affecting the optic nerve. And then Dr. Yagan has very kindly really set the scene for strabismus. So I'm not going to spend a whole lot of time on that, but simply to mention that kind of treatment. Strabismus meaning squint surgery when your eye has a turn, and we straighten it up. And why do we do that? Finally, cataract, not so important, actually, as Dr. Evans has told us, but certainly applicable to some patients. And then finally, vision impairment in adults. Again, it's a rare thing in neurofibromatosis 2, or Merlin syndrome, as is now known. But it's just something to mention for those who are interested, especially if you've lost your hearing and lost some sight. It may be more meaningful to you than anyone else that you have some links or some direction to travel in looking for ways to optimize the vision you do have. So this picture in black, or the pencil sketch, simply shows an area. It simply shows that there's the vestibular schwannoma, or another word for it is acoustic neuroma, which is growing somewhere in the sort of middle and the back of the head. And the 5th and the 7th nerve all travel very, very close to that area. And as a tumor expands, it presses on these nerves. And unfortunately, if you've been one of the people who've had surgery on a large vestibular schwannoma, there's a greater risk that you have lost significant amounts of hearing, but also have had damage to the facial or 5th nerve as a consequence of the surgery itself. So this series of pictures, this is a gentleman who actually has a 7th nerve palsy. What we mean by palsy is a nerve that doesn't work very well, or a damaged nerve. So he's got a 7th nerve problem affecting his left eye. So that's the eye that actually looks a bit bigger to you. But what's actually happening is that he's unable to close the eye properly. So the upper eyelid is stretched back and the lower eyelid is a bit lower. So the consequence of that is that the eye is constantly exposed to the elements. He's not able to protect the eye properly. And what then happens when he closes his eye, this is a really good test that I do in clinic, is to check how well he's able to protect the eye when he's trying to sleep. So when you close the eye, what happens? And what it shows is that 1, a whole lot of the eye is exposed when he tries to close the eyelid, and 2, when he sleeps at night, he's probably not able to close the eye at all. And 3, he does actually protect his cornea because he's got something called a Bell's phenomenon. That's just small print. That's why you see an awful lot of the white of the eye, because the cornea, that clear bit in front of the eye that covers the brown iris, actually goes back into his under his remaining eyelid to protect it. And then the final picture in green, you may have had a doctor drop a little drop of fluorescein in your eye. It's an orange liquid, but when you shine a blue light on it, the parts of your eye that are dry glow green. So the parts of the eye, actually there's little tiny dots all over the surface of the eye, which tell us that actually this person's eye is very dry and needs some treatment. So you probably know from other webinars or other sources that some patients who have severe facial nerve palsies or severe 7th nerve problems can have a special surgery which helps to make the muscles in their face move about a lot more. And this can help in protecting the eye. But even after this surgery, you may still need eye surgery or eyelid surgery to try and close the eyelids better in order to protect the surface of the eye. So this lady who has a severe 7th nerve palsy, after the facial reanimation surgery, sees she's able to smile and, she's able to move her face much better, but her eyelid is still, the lower eyelid is still a little bit lower than before. And this is a person who may still need a little bit of surgery to try and improve the health of the cornea and prevent a dry eye or loss of vision due to scarring. The other important thing to say is when the 5th nerve is affected, you lose sensation to the front of the eye. And that's really critically important because the good Lord designed us in order to be able to feel every falling mote of dust. But when we lose that sensation, it means that we don't blink in response to the eye feeling dry so much. So for people who've lost that 5th nerve or the corneal sensation, it means that eyes are even more exposed and more at risk. So when we are in clinic, we look specifically for the function of the cornea, see where it feels as well as on one side as it does the other, and also for the function of the 7th nerve in order to make sure that we're looking after the surface of your eye properly. And how do we do that? Well, anyone who's had a dry eye or had a doctor tell them they've got dry eye, even if they don't have symptoms, will know that the first thing we reach for is lubricants. And what that is a tear substitute, because our own tears are inadequate, or we just don't have enough of them to cover the eye. So you've got a whole range of products out there, and I'm not here to sell one or another, but I would recommend those who have to use quite a lot of treatment in their eye, quite a lot of lubricants, to use something that's preservative free. That's really important, because if you're using an eye drop more than about 4 times a day, the preservatives alone may cause a little bit of toxicity to the surface of the eye and make them feel even drier, or cause a little bit of additional dryness, which you can do without. So I recommend a preservative-free type of any lubricant that you choose to use. And the lubricants, I basically call them runny to gummy. So it depends on what you like to use. And I have no, and I'm sure Dr. Yagan is also not prescriptive in exactly what you should use, but use something that feels good to you and fits with your life. So for example, if you really only function with one eye, to have something that's really thick and gel-like might not work for you because it'll make your vision blurred. But if both eyes see pretty well, then you might be able to tolerate having something a little thicker during the day in one eye. So on one end, there's the very runny formulations of only showing some stuff without preservatives, and then a gel, usually a carbomer-based gel, which makes your vision blurry for a few seconds, but can feel pretty soothing because it simply sticks to your eye for a little bit longer. It means you might get away with using them less often. You have ointments, some of which are quite a paraffin-based, which are thick and oily, and those are really very useful in the night. And very occasionally, some patients have to use them during the day as well, when their dry eye is particularly severe. And then a question I know that lots of my patients have is, well, what do I do when all of this is not adequate? And although I haven't personally tried these, some of my patients have really found it very useful to use a set of goggles at night to seal in the moisture. And I would recommend they only use them at night for the most part. You can also use a heated mask, which can sometimes stimulate tear production, especially if you have an additional condition called blepharitis, which basically is the glands of your eyelids getting a bit blocked up, and the tears not flowing as freely. So all of these can be super helpful, and your own doctor will be able to advise on how often to use them or what a good combination would be for you. But sometimes it's just trial and error. So really go for it and try different types to see what suits you the best. And your doctor can give you feedback by looking in your eye, and you can give yourself feedback by knowing how comfortable you feel. But of course, if you've got a fifth nerve problem, you may not be able to really assess for yourself exactly how effective a treatment is, because you can't feel so well, can't feel the surface of your eye so well. And then there's surgery that Dr. Yagan has already mentioned to you in brief. So I'm only going to focus on two types of surgery, because they're the most common that we use to protect the eye, especially in a seventh nerve palsy. So the first is what we call a lateral tarsorrhaphy, and that's when a few sutures are placed in the corner of your eye. And this can be done so elegantly and so gently that really you'd barely notice that you'd had a treatment, that you'd had a surgery. So a few sutures on the edge of your eyelids, to just a couple of little stitches. And what that does is enable the eyelids to close a little bit more and provide your eye with just a bit more protection. And that can also mean that, you know, you maintain your visual function as well as you possibly can, and also maintain your comfort and maybe get away with a fewer drops. I certainly have patients of mine who've hardly have to use any drops if they're required to have this procedure done. The second procedure, and I'm not showing any gory surgical photos, Dr. Yagan has done that for me. So these are little platinum, not gold, but platinum inserts. I have no special preference on which ones. Some people prefer one over the other, but these are little tiny heavy and inert metal pieces that are strung together. The weight depends on how much your eyelid needs to drop, and everyone's a little bit different. And you can see in the picture, someone just immediately post-operatively, you can see that little bulge. Over time, that settles down completely, and you can see the arrow in the gentleman below, that his own eyelids have basically covered up the insert, and you wouldn't even know he'd had a surgery done at all. So that's how effective these surgeries are, and it can make a whole difference between a night's sleep and not a night's sleep in patients with eyelid problems due to seventh nerve palsy. So prevention. So of course, this is all fine to treat, but what if we were in a position to prevent or minimize the risk of a facial nerve palsy? Well, a lot of our patients are on Avastin, I'm sure some people in the audience are also. And the Avastin therapy basically keeps the acoustic neuromas the schwannomas as small as possible. And we hope with that comes a much reduced risk of severe facial nerve palsies in patients. And then secondly, timing of surgery. So if you have a vestibular schwannoma, it is very worthwhile having a good discussion with your neurosurgeon about the timing of surgery, because if you catch, and there are reports that if you catch a vestibular schwannoma early and able to treat them when they're small and manageable, you may be able to avoid some of these severe facial nerve palsies following a surgery where, unfortunately, the nerve has become damaged because the tumor is quite big and the surgeries had to be quite extensive. So although it's not so common, I definitely see patients with optic nerve sheath meningiomas and other intracranial tumors that impact on the optic nerve. And that's simply that they grow and then they may press on the optic nerve from the outside of the optic nerve, or they are very, very close to the optic nerves, as optic nerve sheath meningiomas are, and we can see them inside the eye. So here's an optic nerve. So the left-hand image, your left-hand image, is a nerve that's swollen. On the right, it's not swollen, just for contrast. And that's basically an optic nerve sheath meningioma that's sort of growing out. And they're so slow growing, quite a lot of them don't have to have anything done for an awful long time, if at all, especially if they're stabilized. But eye doctors are in the business of monitoring these very closely, monitoring your visual function. And when they threaten your vision, or they grow significantly and look like they're about to threaten your vision, that's when we intervene. By and large, all the data tells us that doing surgery is a bad idea, but radiotherapy is actually very effective and much cleaner in terms of the side effect profile. I don't think I'll offend anyone by being frank about that. But it is important that you come for your appointments to monitor for change, but be reassured the change doesn't happen very fast. And the way in which we monitor, as Dr. Yogan has already mentioned, is with visual fields or with testing your vision. And obviously your MRI scans are very, very important in this. And of course, if you're noticing symptoms, must let us know. So children are a really important group, as Dr. Evans has already discussed. And this is very special people. Because they're so little when they develop neurofibromatosis too. And so it's also a really critical time, because under the age of 8 is the period of visual maturation. What that means is your brain is developing its ability to see. And so if a child has a lazy eye or a turn in their eye when they're little, by doing some simple things like correcting their vision or correcting that turn in their eye with surgery that Dr. Yogan has already mentioned to you, you can restore a lot of visual function. And then finally, part of the multidisciplinary team include orthoptists and optometrists. They check the vision in a very, very detailed way, much better than the average nurse in an eye clinic, but they really get the most out of the vision from children. And children can have impaired vision due to retinal hamartomas that have been there from a very early age. And they can have reduced vision from a turn in their eye. So one eye is just pointing out there. It doesn't get a chance to get all the visual information from the world in order to help them develop their vision correctly. So these are all things that ophthalmologists can tackle. And that's part of the multidisciplinary team, even within ophthalmology, helps to really get children's sight back on track through really diligent observation and monitoring. It's a little girl who's obviously having her eyes tested. So what is this multidisciplinary care? So we test their vision and we check whether they need updated glasses. That's absolutely fundamental in any pediatric ophthalmology or NF2 clinic or any clinic where you're dealing with children in eyes. We do patching treatment to prevent a lazy eye. And then we communicate with schools to tell them what visual problems children are having. So everyone's in the know, and children get extra support to learn. Certainly in the UK, you can have someone, a teacher, a visual impairment teacher, sit with the child and make sure that their learning doesn't suffer just because they have a problem with their vision or they're receiving treatment for their vision. And then finally, special visual aids, so books that may have bigger writing, or children go and sit up front, or have special laptops. So these are all the things that we would ordinarily do for children that's very special to them. And then this is the impact of strabismus surgery. So here's a child who eye points in. By making her eye point straight, what you're doing for her is helping her restore vision in an eye that might be poorly sighted, just because the brain is now receiving visual information from the world outside. Secondly, you may have to do patching to really optimize that vision. So we patch the good eye, so we force the bad eye to really see and use everything in the visual world to stimulate the brain. We make the child able to fuse two images at one time. That's called binocular single vision. So they're able to use both fields of vision at once. And then finally, they're able to get depth of vision, that's stereopsis. So that means that, they can catch a ball that's flying towards them during a game and not miss it, or you pour tea into a cup or milk into a cup, and you pour it accurately into the cup as opposed to missing it. That's the advantage of good depth perception. So that's what we hope to achieve for children in particular. The cataract, as we've already discussed, it's not really something that requires to be fixed very often by surgery, but Dr. Yagan has mentioned it. On the far right, as you see it, there's a picture of a new lens being popped in. On the far left, there's a posterior subcapsular cataract, that white stuff in the middle. It can cause glare and dazzle. And if that's happening to you, then it's a good reason to have your cataract taken out. But your vision may or may not be significantly affected. But when your vision is affecting the activities that you like to do, it's time to talk to your ophthalmologist about taking out your cataract. I often find that people are getting cataract because of age itself, rather than anything to do with their NF2. But the combination of a cataract that was there from earlier in their lives, plus the process of aging, combines the two types of cataracts. And so it might be a little sooner for you to have your cataract operated on than somebody else. But it's relatively easy surgery. It's one of the most common ophthalmic surgeries that you can possibly have done, and it's very safe. Finally, in my talk, and I'll end after this, this is just a link to the Royal National Institute for the Blind in the UK. You'll have something similar in your own countries. But it is often the case that patients with hearing loss are more dependent than ever before on their sight. And so it might be that you're the person that wants to have something to optimize your vision. And there are a whole range of aids, from the things on the far left as you see it. That's a loop to optimize your near vision, so stuff that's close to you, fine tasks. There are all kinds of magnifying glasses, brightly lit magnifying glasses. And then on the far right, there's actually a mouse that if you roll it over something, it actually reads text to you. I don't really see many of my patients with NF2 requiring that sort of a thing, but there are definitely patients who've got dry eye in one eye and maybe poorly sighted in another eye that do benefit from visual aids. So I wouldn't undersell their possibilities. And just so you know, there's something else out there to help if you're the person that requires this. So I think I'll end my talk there, and we're all open for questions.
Thank you very much. Thank you very much. Before the questions, we will just run a little poll that would take a few seconds for you to answer. So I'm going to launch it now, and please answer to the few questions if you want. Then we will share the response with the panel later on after the webinar. So they know roughly who was the audience, what are the kind of concerns the audience have. Yes. 35% of the audience responded so far. It's increasing. 50% now. Okay, thank you very much. I'm going to close the poll. I hope you had time to answer. Oh, I still see a few more coming in. Okay, let's wait 5 more seconds. Okay, thank you for answering the questions. And now we will go through some of the questions that you submitted when you register to the webinar. Okay, so first questions, we have a question from Claire Godard. She's asking that if your child has no visual disturbance, does it mean that it will not develop later, or it can still develop in the future? So if you can jump in, Dr. Yagan or Dr. Sharma or Dr. Evans. So if there is no eye issue while the person is a child, can it develop later on?
Well,
Sorry,
yeah,
go ahead.
carry on.
Go ahead. No, go ahead. I was going to forward it to Sri because I don't see pediatrics, but
I mean, the amblyopia, the sort of lazy eye, will be something that will be there from early on. That's unlikely to develop later. But obviously some eye features, so that retinal hamartoma, the juvenile cataracts are there from very early. But obviously some of the features can occur later in life. So optic pathway meningiomas, although they can occur in childhood, can occur later and can cause visual loss. So you're not guaranteed, if your child is 10 and haven't got any visual problems, that they're not going to get them later. And of course, facial weakness and weakness to the trigeminal nerve that gives sensation can affect vision as well, with dry eyes and problems later on, and that can be related to the surgical treatment. So unfortunately, we can't guarantee that vision will not deteriorate if you've got a child with perfect vision at 10. Don't know if you want to add to that.
Thank you. You are on mute, Dr. Sharma. Yeah.
No, I think I would agree that I think the chances are low, but it really depends whether they have any problems that could potentially impact their vision later on, even if they don't at a particular time.
Thank you. A person asked, or say that he say that, are you making patients aware that Avastin can cause severe dry eye? So any experience that you have with people taking Avastin and the connections to dry eyes?
Well, we've treated, yeah, carry on.
I'd say that I actually don't have that experience at all.
Neither do I. We've treated about 160 in the UK, and I'm not aware of any. I mean, they might have occurred, but you've got 2 centers here that have treated over 100 patients, and neither of us are aware of extreme dry eyes as a result of Avastin treatment.
I guess the difficulty
It may be a rare side effect.
Yeah, I guess the difficulty is dry eyes is such a common thing that
exactly.
It's really difficult to know whether it's caused by facial nerve problems, whether it's from the trigeminal nerve problems, or just a common sort of dry eyes problem, or is it really linked to the Avastin? But as you said, to our experience, it's not one of the main features that we kind of pick up anyway.
Thank you. Also questions about how often would you suggest eyes to be examined? So maybe you can divide it into 2 groups, maybe the group of people that doesn't have any eye issue, and NF2 people that doesn't have any problem with their vision, how often they should still go to the ophthalmologist. And what about the others, the one that have some issue with their vision, how often they should go to the ophthalmologist?
If I can address that, and I'll take a risk. I'm on letting you know my own practice, which is that I'm fairly pragmatic. If you have, retinal heart, if you have no visual problems at all at diagnosis as an adult, then, the chances of developing one really later on, and you've got no cause to develop one later on, then I would say that I probably don't really need to see you for about 3 years. And I do that just simply to make sure that, nothing new has developed. So 2 or 3 years. So, but if someone says, look, the schwannoma is expanding rapidly and we can't get on top of it, there's some dry eye, then of course that would prompt me to see you within that time. If you have a problem with your vision already, it really depends what it is. So for example, if you have dry eye, I would probably see you more frequently than someone who just has a retinal hamartoma, which is very stable and may only see you once a year.
Yeah, I'd echo that actually, Sri. I think if there is no symptoms or no features, ophthalmic features, I guess the only difference, if I may suggest, that you could probably get seen by your own local optometrists if there is no ophthalmic features at all. And the usual advice is to see your optometrist every 1 to 2 years anyway. And if there is any changes, then you get referred again. But if there are features, then definitely it really depends on what the findings are, and it might be very frequent or it might be once a year type thing.
Thank you. About cataract, so if there is a juvenile cataract, how soon, and if it needs to be removed, how soon can it be removed based on the age of the patients? In my personal case, for example, I know that we have been told that we have to let the eye grow before we can remove it. But is there any minimum age for surgery, cataract surgery?
Not really. I mean, but let's confine ourselves to this particular group of patients, because otherwise then we're talking about all of childhood cataracts, which I don't want to get into. But this particular group, you would tend to diagnose them at an age, 4, 5, etc., upwards, right? And most do not need surgery. If your vision is good, then there's no requirement to do surgery. If your vision is excellent, it's absolutely no requirement to do surgery. If your vision is impaired, then of course, then surgery is appropriate, because what you want to do is make sure that the vision is good during your period of visual maturation, and you prevent a lazy eye developing. But
do you have to wait for a minimum age before that surgery?
No, there's not really, because I'm talking about this specific population. The 4 or 5, is probably is the youngest that I tend to see patients with manifestations of NF2, and I would say that's, if you needed to, that age is fine.
Yeah. As long as it's visually important, it's affecting vision, then yes, the sooner the better. But it's quite a rare thing for the cataract in NF2 to be visually affecting.
I have never seen one. Put it that way.
Yeah.
I agree. It's really rare. So that's the thing, that the take-home message should be: although there are lots of eye features, it's actually pretty rare for them to cause visual loss. So I mean, we do see older patients with lots of meningiomas where it causes raised intracranial pressure, and that can cause problems with vision. But that's a slightly different issue. It's not the actual eye themselves problem.
Yeah, correct.
Questions from Mary Wong. About congenital hypertrophy of the retinal pigment epithelium. So is it helpful or a waste of time to patch the good eye in that case?
I would say you get the vision as good as it can be. So let's just say you have, I'm not sure where you're from, Ms. Wong, but let's just say you have 20, if you're in the States, 20/40 vision, the UK 6/12 vision. If that's your retinal hamartoma allows you to see that well, but in fact, your vision is a bit lower than that, and it's a child, then patching is very helpful to get it up to as good as it can be, but you can't really push for more than that, because it's just not achievable.
A question from Bruno Damasia. How to deal with double vision due to sixth cranial nerve damage?
I think that's a question for Dr. Yagan.
Yeah, so there are multiple options. It depends really on how bad the sixth nerve palsy is and how much of a what we call a squint or a drift of the eye there is from that sixth nerve palsy. But in simple terms, there are three options. One is what we call prisms. So there are specific sort of additions to glasses that helps not necessarily change the position of the eye, but helps join the images together and get rid of the double vision. If that doesn't work, sometimes we do Botox injections to the what we call the inner muscle of the eye to try to relax it a little bit and create some balance. Problem with the Botox, it has to be repeated relatively frequently, something like 3 times a year or 4 times a year. The third option is surgery, similar to the images that I show, the gory images that I showed in the presentation, where we operate on the muscles around the eye to try to get some balance back to help with the double vision.
Thank you. Questions from Owe Owen. Do epiretinal membranes tend to worsen in NF2?
My own experience is that they don't really tend to progress very much. Neither do the hematomas.
Yeah, I echo that. I think the few patients that we had with hematomas and epiretinal membranes are relatively stable over a very long period of time. There is very little change over time in these, which is
I agree with that.
Which is good, I guess.
Question from Kimberly Tracy. Stacy, you talked, Dr. Sharma, about the optical nerve tumor. But her question is, what treatment is available for non-operable optical nerve tumor? So let's say you cannot treat it with a surgery. You talked about radiation. So maybe you can speak a little bit about the success rate of the radiation on the optic nerve and how it influences the vision, and any experience as well with proton beam could be good to.
Yeah,
well.
I'll, as a disclaimer, I don't have much experience with proton beam, and I would defer to my oncology colleagues to give specialist advice about that. I can tell you that the data from stereotactic fractionated radiotherapy for optic nerve sheath meningioma generally promise stability of a stabilization of the optic nerve sheath meningioma in about 60 to 70%. And so that is the first line treatment in my view for adults with an optic nerve sheath meningioma. And I don't know what is meant by non-operable. In general, I would advise don't operate. Yes. Yeah, I think it's a good thing. Someone's told you they're not willing to operate on it. Hopefully that means that they've got an alternative that they're willing to suggest to you.
Yes.
So there is a drug that is promising but isn't yet licensed called brigatinib that appears to have some activity against meningiomas. So we actually have a patient with fairly advanced meningioma disease that's affecting the eye nerves, who we are trying that on at the moment. So you can sometimes get these things off license, a sort of compassionate treatment, if you like. But I think there needs to be a very strong case to the drug company to be able to do that, because they're still obviously gathering the evidence to try and get the treatment license for treatment of NF2 related meningiomas. So that's a possible treatment. In terms of radiation, I'd be wary of treating children with radiotherapy because of the growing tissues and the possibility of inducing more problems down the line, either more meningiomas or the possibility of even inducing a malignant tumor. So although that risk is relatively small, it's by no means zero, and really isn't something you see in the one-off sporadic meningiomas when you treat with that type of radiation.
I agree. I think it's quite tricky. Luckily, they are not that common and they don't grow that much.
Yeah,
but
I agree.
they are quite challenging to treat because operation and surgery is kind of the last resort, because that really sacrifice vision, and radiation involves kind of creating risk of further tumors later on. So we can say yes, we use quite a lot of it in sporadic sort of meningiomas, but not in NF2, or at least we try to avoid it in NF2 if possible.
And we have two questions here in the Q&A that was asked about also the optical nerve meningioma. But if I understand well, they ask about the direction where it grows. So once Monica Firestone asked if it grows toward the chiasm, I don't know how to pronounce the word, sorry, chiasm.
Chiasm. Yeah.
Chiasm in children. And another question similar, say if it's growing into the cavernous sinus. So is there any trend or pattern on how it grows, in which direction it grows?
Gareth, I guess it grows in either way. There is no real kind of evidence, to my knowledge, that it grows favorably in one direction than the other. It's always how you monitor it and pick it up with time, unless Gareth have another idea about it. I think we lost Gareth.
Yeah.
Sorry, can you repeat that question?
Yes,
my internet just flickered out there.
So Gareth, the question was really about the direction of growth of optic nerve sheath meningiomas. Do they grow more towards the orbit or more towards the chiasm? Is there any preference?
Yeah, I mean,
growth pattern.
I think they can grow towards the chiasm, but I've not seen any unilaterals become bilateral by growing towards the chiasm and growing around the other side.
Yeah.
And the other questions from Monica Firestone. Do you ever prescribe everolimus for children optic nerve schwannoma? Because it has been shown that everolimus is acting a little bit on meningiomas as well. Is it something you have seen, maybe Dr. Evans?
Well, we haven't used everolimus. Yes, there is some evidence that it's called cytostatic, which means it might slow the tumors down or stop them, but not shrink them. But we actually haven't really used everolimus. The data isn't that convincing, but yeah, I mean, it's an option that can be discussed. I know that it's something that's used in Paris a lot by the Michel Calamarides and the people in Paris, but we haven't been a big fan of it yet in the UK.
Thank you. And another question from Monica: if vision is already gone, is surgery still a bad idea? I mean, is there other risks of doing that surgery? But
I guess we operate in a vision in an eye that, well, behind an eye that's lost its vision if the tumor is big enough to disfigure the face. So like the picture that I showed of the patient who had a very large optic nerve sheath meningioma and his eye surface was pushed forward and affected, then yes, you can operate on these to try to create more space in the eye socket and preserve the shape of the eye and the eye itself as an eyeball, as a tissue rather than a vision organ, if the vision is already gone in that eye.
thank you. A question about the strabismus. Sorry, is strabismus surgery only offered after treatment of a tumor that is thought to have caused it, or is it realistic to pursue prior to treatment of the tumor?
No, I think actually we would want some period of stability before offering strabismus surgery. So we need to make sure that the offending tumor or structure has either stopped growing or has been dealt with prior to doing anything surgically in strabismus. We can do prisms, we can do Botox, but usually surgery is after the tumor being dealt with.
Okay. So thank you very much. We still have other questions, but we will share with you the questions by email, and hopefully maybe you can answer to some of them, and then we will share them back to the audience.
Absolutely.
I would like to close by showing one more slides. So like kind of announcement, we are collecting blood now from NF2 patients. We have a way to collect them, to send someone to draw you the blood and send it back to the NF2 biobank. We can do it only in USA right now. So if you would like to participate in this blood collection, it will be used for doing genome sequencing, but also for NK natural killer cell project pilot at Nationwide Children's Hospital. So that's one thing. We are going to also, it is also posted on our Facebook page. So if you use your phone and take a photo of this QR code, you will be reaching a form where you can sign up and we will contact you. And again, please support us so we can have more of these webinars in the future. And you can also check our YouTube channel to see all the previous webinars. So I would like really to thank you, Dr. Sharma, Dr. Yogan, and Dr. Evans for the time you spent for the preparation of these slides. That's very, very nice from you. It's I know ophthalmology is something often that is a bit left aside. We have so many doctors to go to visit, oncology and ENT, neurosurgeon, and we have tendency of forgetting a little bit to take care of our eyes. So I hope that this webinar will be very useful and will make people realize that we have to step put on our vision treatment. Thank you again. And this webinar will be posted next week roughly on YouTube, and hopefully you can all look at it again, and we will try to answer to all your questions during the week. Thank you very much.
Thank you. Thanks.
Okay, thank you.
Bye.
Bye now.